My name is Kim, and it's my pleasure to be chairing this today. Now, while people are still joining, I just want to give a quick shout out to our partner charities, the Pelvic Radiation Disease Association and the Eve Appeal. They've been awesome in helping us promote this webinar, so thank you to them. Thanks also to the webinar team, Sam, Joe and Zoe, and Rhea's mum, Vasilia, for helping make sure that we run this smoothly and hopefully on time. If we have any technical issues during the webinar, please bear with us. If you have problems with your audio and video, then just try logging out and rejoining, because that can fix some of the common issues. Also, we've got a hashtag, RTLateEffects, so please feel free to tweet along, and a couple of us will be online afterwards, and we can carry on the conversation on Twitter for any follow-on discussions. So, as you know, we're going to be talking about the late effects of radiotherapy. We've got clinical experts, Helen Ludlow and Lisa Durrant, who are going to provide an introduction to late effects and discuss the clinical management, as well as some research that's happening in this field. We'll then hand over to Rhea, who's going to share her story, her diagnosis of cancer, her treatment and her subsequent side effects. It should all take around about an hour. We're going to have some time for questions as well. Talking of questions, you can use the Q&A feature, which is at the bottom of the screen. Feel free to ask questions throughout, and our speakers will try and answer them, and we'll save a few up for the end as well. Just be aware that we can't really take any questions on individual circumstances or individual treatments. But the exception is Rhea, who's happy to answer questions about her experience, but please nothing too sensitive or personal. So before we begin, I just have some general considerations about the content of the webinar and our audience. Now, we're really pleased to welcome such a wide variety of people to watch this. We've got patients and carers, healthcare professionals, educators, students, and many others. I just want to make you aware that we're going to be discussing symptoms and side effects of cervical cancer and its treatment. It's primarily based on one person's experience, and of course, everybody's experience of cancer and treatment is different. For instance, radiotherapy is very individualized, so side effects can vary from one person to another quite considerably. With that in mind, some of the content might cause you to recall difficult past experiences, especially if you've had cancer treatment, and it might make you worry about the future too. We just want to make sure that everybody feels well supported throughout, and we've got some great resources at the bottom of this slide for support. So please reach out if you feel affected in any way by any of the content, and always contact your own healthcare team if you've got any concerns. A final note to say that any of the resources we share throughout the presentations, we're going to make them available to the attendees afterwards with the recording, so don't worry about missing anything. Okay, so let's get started. It's my pleasure to introduce to you our first speaker, Dr. Helen Ludlow. Helen is a clinical nurse specialist in inflammatory bowel disease. She's a Macmillan nurse for gastrointestinal late effects, and Helen is based at Cardiff and Vale University Hospital in Wales. She did her doctoral research on people's experiences of living with the late effects of pelvic radiotherapy. And Helen's going to introduce our topic and share some of her research with us today. So thank you, Helen. Handing over to you.
Lovely. Thank you very much, Kim, and thank you to everyone for putting on this evening, and to everyone listening, either hopefully at home, possibly still in work. So as you can see from my job titles there, I do spend most of my day actually within the bowel or talking about it, and it's one of the most interesting organs there is. So I'm really happy to be able to talk to you this evening about it. So to start off, I want to tell you about some of the main symptoms that I come across in clinic. So if I could have the first slide, please. Okay, so I thought this would be helpful for not only the healthcare professionals among us this evening to recognise in their own patients, or possibly any patients that have linked in to see if they're having these issues too. Urgency of stool. So that really is one of the most common things I hear about. And I think that is because it really does impact on what people do, where they go, can they go, are there toilets there? So that seems to be one of the most problematic symptoms. So rectal bleeding, now any form of bleeding from your bottom is not normal and it should always be investigated. It's quite commonly quite a simple problem, you know, and as long as you know what it is, that's absolutely fine. Mucus is quite common because of either inflammation or irritation there in the bowel. And diarrhea, that's probably one of the second most common complaints I hear about. And particularly if you've got that diarrhea and urgency, you're possibly really going to struggle there, potentially resulting in some fecal incontinence. Constipation is actually quite a common issue as well. And more commonly than not, it's going to be a combination of diarrhea and constipation. Those are the issues down the bottom there: bloating, borborygmy and flatulence. So that borborygmy, one of the best words in the English dictionary. And that is where the stomach is really growling. So it's not just that sensation you get when you're hungry and you're a little noise. This is a real loud noise that other people in the room can hear. And obviously, you know, that can affect people in work, or if they're going out, they're not going to want to go to the cinema or the theatre in case there's this really loud noise. And then fatigue at the bottom, again, a very common symptom for most chronic diseases, but certainly after cancer treatment again. So what is going to be the best way to identify people that are struggling with these symptoms? So next slide, please, Kim. This is the Alert-B screening tool. So it's the assessment of late effects of radiotherapy linked with the bowel. So it was developed from the EAGLE study, which was a big research study, multi-site research study, looking at men with bowel problems after prostate cancer. So it basically is split down into three very simple questions. The first involves bowel control, the second bleeding, and the third one there, affecting your quality of life. Now, just because you might tick yes on one of these boxes does not necessarily mean that that person needs to have the whole host of investigations. But what it does do is encourage further conversation, further questioning, what is bothering that person, and would they like some help with that? What I like about this tool, because of its simplicity, is it can be used in any setting. It doesn't have to be formally given out on paper, but it can be pinned to waiting room walls, clinic room walls. It can just be in that conversation between even your own family and friends. It's basically just to identify who is struggling and needs further input. So next slide, please, then. These next few pages, this is the paperwork that I use in my clinic. That part on the left there with all the boxes, that's basically a simplified version of something called the GSRS, which is the Gastrointestinal Symptom Rating Scale. So people can put a tick in the box, and that lets me know what is the biggest problem for them. So for example, I don't know if you can make that out, but those two columns on the right, it says frequently affecting your life, causes major changes to your life. If someone puts a tick in those boxes, then I can tell that this is a real problem for them. On the right-hand side, then at the top, there's two little scales there from 0 to 10. And that again is telling me how much of a problem this person is finding their bowel symptoms. The middle and lower part there, Bristol stool chart. Again, that's just a visual tool for me to see how often that person is going to the toilet and what is the consistency of stool. Because again, that really points then to what we need to do next. So once I have this information, I can then move on to this next step, which is the next slide then, please. Now this document, there will be a link towards it at the end, or you can take a screenshot of that or write it down. It is widely available. And if you Google that title, anyone can access it. And therefore, anyone, any healthcare professional, any patient, and it's easy to see what to do. The little shot there of the page on the right-hand side is a typical example of what is within this document. You'll see at the top there, it says diarrhea. So there is a page to match each of those symptoms that I had identified there on the earlier page. So if diarrhea is a problem, there's a list of investigations, a list of potential results, and then a list of potential diagnoses at the end there. And towards the back of this booklet is then, once you have these diagnoses, what are you going to do about it? And again, the reason I like this, as I said, it's widely available, and you don't have to be a gastroenterologist or a specialist in bowels to do much of it. So, you know, if your healthcare professional is aware of this, and they are willing and able to have a little look through it, it can certainly be a really good step forward. So moving on then to the next slide, please, what potential diagnoses may be made and the treatment. So due to time, I can't really go through the treatments in any depth here, but the diagnosis, and these are the most common ones that I find. That first one there, radiation proctopathy. It is not an itis. Anything with an itis on the end, proctitis, indicates inflammation. This is commonly mistaken to be a proctitis, which means therefore you get the wrong treatment. Radiation proctopathy is caused where the radiation has damaged the tissues and caused scar tissue, but it's actually the body trying to repair itself and sends out these little tiny blood vessels to revascularize the area, so try and make it healthy. They sit too near the top and they bleed, and that's often what is causing this rectal bleeding. Bile acid malabsorption. All our bodies create and use bile acids to break down your food, and they should be reabsorbed in a certain area in your small bowel. This area is quite commonly hit with pelvic radiotherapy, and therefore it's not reabsorbed properly, and that awful acidic bile stays within the colon, causes all sorts of mischief in there, including bloating, diarrhea, abdominal discomfort. Lactose and fructose, they're carbohydrates that are in many of the foods we eat. And for various reasons, your body can lose the ability to break these down, and you can become quite intolerant and cause, again, a lot of bloating and discomfort. Small intestinal bacterial overgrowth, or SIBO, you may have heard. We've all got millions, if not billions, of bacteria on our colon. They exist alongside good and bad bacteria, and there's this happy relationship there, and they're all needed there. But for various reasons, including radiotherapy or surgery, these bacteria travel upstream into the small bowel where they shouldn't be. They literally give off gas, they burp and they fart, and they create a lot of bloating, abdominal discomfort, diarrheal symptoms, again, that can be really bothersome. Those blood results there, low vitamin B12, vitamin D. So vitamin D deficiency is actually very, very common, and you've probably heard a lot about it in the press recently because it's sort of linked with all sorts of things. And I do actually find that most of the patients I see are vitamin D deficient. I know I am. The government recommendation is that we should all be taking a supplement through winter months in particular. But vitamin B12, that can be a real cause of lethargy, so you definitely should be checked. That bottom one there, exacerbation of irritable bowel syndrome, IBS, that is probably the most bothersome thing because there is no way of diagnosing IBS. A diagnosis should only be made of that if you've basically excluded everything else. So it's where the bowel, it doesn't function properly, it's very grumpy, it's spasmy, it's crampy. Someone may not have had these symptoms before and now have them, or they may have had mild symptoms and now it's a real problem for them. It is a tricky one to manage there. So just next slide, please. So I just wanted to tell you a little bit about the study. So I actually started my doctorate role actually before I became the Macmillan nurse, looking after people with late effects. and realised that there was very, very little information out there about people's experiences of what it is like to live with these issues. I undertook a literature review, which again, although there was increasing number of literature out there about the symptoms, again, who was talking about what it was like for the person to live with these? Very little. As you can see, my study was admittedly small. The reason for that is because I was working full time and didn't have any study leave to do it. So it needed to be manageable. But I genuinely believe that I managed to get quite a good, good understanding of what was going on. I went into people's homes to interview them, and that really built up my relationship with them. And we found it really helpful. I analysed it, basically that's a jazzy word really, for themes. I found themes. But the next slide is just going to show you some examples of what that my participants told me. Even looking at this now, I find it quite upsetting to read what these people were experiencing. They were speaking from the heart about the difficulties that they were having from bowel effects after their radiotherapy. These were people that before their radiotherapy treatment did not really have any significant bowel problems. Their cancer treatment was over, and then they're hit with this. And I still find it, as I say, quite troublesome to read even today. So the three main areas, these next three themes, if you could just move the next slide, thank you. These are my main things that I identified from my study, that fecal incontinence, but particularly the fear of fecal incontinence, was an overriding theme amongst all my participants. Some people were actually regularly fecally incontinent. The majority had never been, but because of that urgency, this was their absolute dread. And this fear ruled their lives. It ruled everything that they did in case they were going to be incontinent. I was distressed to say that there was again, an overwhelming lack of awareness and support from healthcare professionals from all levels. And then that bottom one there, a drop off of support. Again, nearly every single patient said, you know, while I was going through my cancer treatment, my friends and their family, they were there for me. And it was almost as soon as that treatment ended, everyone's sympathy ran out. They didn't want to hear about these people's struggles now. And that was very difficult for them. So the next slide then, please. So just to summarise what we do know, the incidence of all cancers is unfortunately increasing, but particularly pelvic cancers, and therefore the number of people that are going to be receiving pelvic radiotherapy is also increasing. We know that this pelvic radiotherapy will cause damage to all the structures in the pelvis. This is not just about the bowel. I've talked to you tonight so far about the bowel, but it also affects the bladder, ureters, vagina, anything within that pelvis. So it's got this umbrella term, pelvic radiation disease, that you may well hear being talked about. The Alert B, it's a very quick, simple assessment tool. Again, you can Google it and print it off. More than happy for that to be done. Late effects of radiotherapy have a significant impact on the patient, their family and their friends. There's no doubt about that. And unfortunately, there is still a lot of work to do about improving awareness amongst everybody. So my last slide there, the next one. If I had a pot of money and some time to do this, this is my my golden questions that I would like answers. What is the best way to support people? Should it be individual, support groups, disease-specific support groups? I actually struggled to set that up. People often don't want to talk about their bowels. How can this drop-off of support be addressed? Who should we be concentrating on? Is it the patient themselves to make them more braver, should we say? Is it their family? Is it their friends? How should we be addressing that? Urgency of stool. What can we do about that? This is not the normal thing that's going on there that other conditions deal with. There are structural changes to the tissue. So what can we do about sorting out this urgency problem? And how can we better engage other healthcare professionals? It's fantastic this evening that so many people have joined us, but there is an awful lot more work to do, and how can that best be done? So the next slide just shows my contact details. If anyone's got a burning desire to get in touch with me, more than happy to share any of my paperwork. I think some of the details will be available at the end, but I'll pass you back to Kim now so that we can crack on with the rest of the evening.
Thank you so much. Thanks, Helen. That was fantastic. Some really powerful quotes uncovered in your research, and I love your golden questions for how we can move things forward. Okay, so on to our next speaker. It's Dr. Lisa Durrant, and I am thrilled to introduce Lisa. She is the Macmillan Consultant Radiographer for Late Effects at Musgrove Park Hospital in Taunton. For some time, Lisa has been the oracle in the radiotherapy world when it comes to late effects. So we're really pleased to have her here to share some of that knowledge and experience with us. So thank you, Lisa. Over to you.
Thanks, Kim, and thanks to Helen as well. Can I have my first slide, please? Thank you. So during pelvic radiotherapy, many patients develop acute side effects such as reddening or breakdown of the skin, diarrhea, or needing to urinate more often. Acute side effects start during treatment and usually resolve 2 to 4 weeks after the treatment's completed. Long-term side effects such as hair loss or lymphedema can also start during radiotherapy, but take much longer to resolve, or perhaps don't become better at all and become permanent changes. And then late side effects such as changes to bowel, bladder and sexual function can occur many months to years after radiotherapy and often permanent and progressive. The key feature is that these are side effects that aren't present during the radiotherapy but develop sometime afterwards. Next slide, please. So why do we develop late effects? It is because normal tissues also receive a dose of radiation during the treatment. So the beam we treat with goes in one side and out the other. During the recovery process, an ongoing inflammatory-like process leads to changes such as development of new fragile blood vessels, loss of elasticity, and fibrosis when tissues become stiffened and scar-like. For gynae cancers, we treat large volumes of the pelvis, and this colour map shows how much of the area receives a radiation dose. And we also use brachytherapy to boost the area of the tumour to very high doses. And we know that over time, even low doses can cause changes in normal tissues, and the risk of developing late effects does not diminish with time. Next slide, please. So how do these impact on different parts of the female pelvis? So Helen's very nicely described some of the changes in the bowel, and as she said, there's many more structures in the pelvis that are also affected. So management of late effects is a long-term challenge, potentially needing lifelong solutions. So therefore, I always start with lifestyle advice first, simple things that people can take charge of and implement themselves without the need of medication or difficult daily routines and procedures. If lifestyle changes aren't effective, then we look at conservative management and tests. And then for patients with very complex and difficult issues, local and national services may be required for surgical interventions. So I'm not going to go through everything in detail, and there's lots of issues like pain, fatigue and psychological concerns that I don't have time for today, but please feel free to look back at the slides and get further information if required. So firstly, if we look at the bladder, long-term radiation changes cause a loss of elasticity, hardening of the bladder wall. So storing urine becomes difficult, can lead to frequent trips to the toilet or urinary incontinence. So for conservative management, radiotherapy can also change the bladder lining and cause radiation or interstitial cystitis, which leaves the nerve endings exposed to urine. It's painful, it can cause new fragile blood vessels to form, which can bleed. So using a catheter, you can instill a special solution back into the bladder, which has got hyaluronic acid, which is part of the normal bladder wall, and you can reline the bladder and help reduce pain, infection and bleeding. Very rarely, the damage to the bladder can lead to really frank bleeding and perhaps fistulas, which are holes in the bladder wall, or render the bladder completely non-functional. And at that point, specialist advice and referrals are needed for surgical management, with perhaps laser ablation of blood vessels or urinary diversion. The tissues of the vagina are also affected by radiotherapy, again becoming stiffened, losing elasticity and lubrication, which has implications not only for sexual activity, but also for future internal examinations. So as a first line, I often look at prescribing vaginal moisturisers or lubricants to improve the lining of the vagina and comfort. Vaginal changes are also linked to a lack of estrogen. So we know that pelvic radiotherapy can cause ovarian changes and menopause in younger patients. And younger patients should be on hormone replacement therapy as long as their tumour is not hormone sensitive. Now, there's a really powerful report from the Joes Trust that found that 2/3 of women experience changes in their sex lives following treatment, and sexual morbidity can have a huge negative effect on quality of life, and it should be addressed. So in Somerset, we're quite lucky because we've got both a community sexual health clinic and a pelvic floor service where patients can get psychosexual counselling and physical examinations for advice on psychological issues, pain and function. Next slide, please. So moving on, as clinics develop, I'm starting to see more and more patients with pelvic insufficiency fractures following radiotherapy. These are like tiny, tiny hairline cracks in the bone of the sacrum or lumbar vertebrae, and they occur under normal everyday activities. Many people don't find any symptoms for them, but some patients are completely disabling, cause devastating pain, changes in sensation, changes in bowel and bladder function. So the current guidance is for patients to rest, take pain medication, and when your fractures are stable, have some gentle physio and exercise to regain condition. But rehab can take several months, and I've actually got patients who found it far more distressing than their actual cancer diagnosis or treatment. Lymphedema following radiotherapy is a long-term condition where fluid comes trapped in the legs, genitals or lower abdomen. Surgery and lymph node removal are the main risk factors, but radiotherapy can actually make it worse or be a primary cause. There isn't a simple cure or medication to help, and some people can accumulate many extra litres of fluid, which is heavy, painful, and an infection risk. So moving around, getting clothes to fit, sleeping, altered body image are all challenges that patients face. Regular manual lymphatic drainage massage and tight compression garments are the mainstay of management. And then the last side effect I want to look at in our kind of whistle-stop tour is nerve damage and neuropathies. So there's very little published about the development, diagnosis and management of radiation plexopathies. Patients seem to present with a potential pattern of symptoms, so loss of sensation in the feet, creeps up the lower legs and the anterior thighs, they lose their reflexes in their ankles and then their knees. In the 70s and 80s, breast cancer treatments are a bit less developed than they are now, and patients are finding many years later they were losing function in their arm on the treated side due to damage to the brachial plexus. And as a result of this, the National Breast Radiotherapy Injury Rehab Service was set up in Bath, where they use quite a holistic method to help these patients. So it's a residential course, you get pain management, occupational therapy, psychological counselling, and quite often hydrotherapy, which works to good effect. The centre at Bath has now reformatted itself to the National Complex Cancer Late Effects Service, and it's open to pelvic cancer patients as well, and not just breast cancer patients. Next slide, please. So I hope it's given you a sort of small insight into some of the challenges and management strategies for pelvic late effects. But actually, many of the questions you posed when you registered for the webinar related to the impact on the patient and their quality of life. And this slide shows a patient journey from diagnosis. Now, this isn't Rhea's journey, but another young cervical cancer patient. Each blue dot on the graph there is an outpatient appointment at the hospital. The horizontal axis along the bottom shows time in days, so that's 1,000 days since diagnosis. And the red line denotes the end of radiotherapy and the end of treatment, when supposedly the patient is discharged and returns to their normal life. However, late effects has meant that life now consists of ongoing hospital appointments and interventions. And you have to bear in mind that this is just outpatient appointments. It doesn't show primary care appointments or perhaps more personal issues such as days with anxiety or pain. At the bottom, there's a report which is a good read called Revealing the True Cost of Cervical Cancer. And it shows that late effects are much wider than just physical symptoms, and living a normal life, working, family commitments become increasingly difficult. One thing we perhaps need to consider, though, is the future. So all the discussions we've had so far have revolved around patients who have actually developed life-changing problems. And on the next slide, it's got some different scenarios for the management of late effects. So the first is a current situation for many patients in the UK. So following pelvic radiotherapy, and that's the little green person with the red dot, we're very inactive in supporting these patients post-treatment. The patient develops complex health issues, the burden of symptoms is high, and the quality of life is low. The second scenario shows the majority of late effects care and how it currently works. So we're very reactive. We wait for the patient to develop life-changing symptoms before they seek help and before we offer support. But what we really should be striving for is the last scenario. And its character here is a therapy radiographer supporting the patients throughout their treatment. And hopefully then we can be more proactive in our care and perhaps prevent patients developing serious late effects. So either by predicting those at risk of late effects, so patients can make informed choices before they start their treatment, identifying and treating late effects earlier, as early intervention is a really strong tool in the management of many symptoms, or by preventing late effects, perhaps we can reduce or in fact stop patients developing life-changing symptoms. Next slide, please. So if we look at the management of radiation late effects again, but this time with a view to being a bit more proactive, we know the only way to prevent radiation damage to normal tissues is not to deliver any radiation dose to them at all. So we should plan and treat with strategies to ensure the best treatment is delivered each daily fraction. We should also be thinking very carefully about organs at risk, and these are the normal tissues that we're trying to avoid irradiating. So new guidelines have only just been published with global consensus which defines organs at risk, and for the first time the lumbosacral plexus has been included, as well as the jejunum and ileum, which are parts of the bowel which pelvic radiation can damage and cause bile acid malabsorption. Prior to and during radiotherapy, we can also identify patients with pre-existing conditions that may affect the outcomes, or monitor patients for subclinical signs of potential problems such as lymphedema. It's also been known for a long time that patients who develop severe acute side effects during their treatment are often the patients that come back with late effects, and we could be proactively managing them. So finally, ensuring that patients have the correct information with treatment summaries and care plans enables self-awareness and provides referral routes for patients to get support sooner rather than later. Next slide, please. So hopefully this webinar has shown that radiotherapy is not only a very effective treatment, but it can have a long-lasting and life-changing effect. So being a late effects radiographer is still a fairly new and developing discipline. However, we've got a really important role to play in preventing late effects and supporting our patients into the future. Thank you for listening.
Thank you, Lisa. That was fantastic. It's so valuable to get a bit of an insight into the role that therapeutic radiographers can play in this pathway, and identifying those risk factors early is so important. Okay, so we are ready for our headliner, Rhea. So Rhea is a powerful patient voice and a passionate advocate. She's a published author on radiotherapy late effects. She's also a medical advisor for the Pelvic Radiation Disease Association. And in her spare time, she's a clinical nurse specialist working in North Devon, specialising in pain, ironically enough. So I'm going to hand over to you, Rhea. Thank you.
Thanks, Kim, for the very flattering introduction. I'm aware of the time, so I'm going to crack straight on. If you can get the next slide, please. So this first slide is just to kind of give an overview of what led me to my diagnosis and then my treatment. I'm not going to focus on all of it because we don't have much time, but I just wanted to raise one of the big red flags that led me to getting investigated for cancer in the first place, which for me was abnormal bleeding. So my bleeding was abnormal as it was during pregnancy, which is quite rare to develop a cancer during pregnancy. And that acted a bit like a red herring. So it kind of threw people off the scent for what it could be. So that led to my investigations and my diagnosis being delayed slightly. And the reason I raise this is because actually that brings with it an extra host of anxieties and thoughts and what ifs about, you know, if it had been picked up earlier, would my prognosis or my staging be better? And for health professionals, that's really important to remember that, especially during COVID, when people are having their investigations and treatment potentially delayed due to issues in services, that it's really important to remember that it brings up different issues for them than if they've been investigated and diagnosed quite quickly. I was lucky that my pain and bleeding continued after I'd had my little boy, and my GP was very, very quick to pick up on this. Now, I was advised during my pregnancy that I needed cervical screening once I'd had my son. However, my GP was on the ball and realised that actually I needed investigations, not screening. You know, cervical screening is a fantastic tool. I've always had mine. However, it is a tool to look for precancerous changes, things that can highlight risk, whereas what I needed was investigation to look at what the actual symptoms were because I presented with those red flags. Next slide, please. So once the GP referred me, very, very quickly, I had my investigations. Again, I won't go through all of them. They're there for kind of a bit of a history. The ones that I'd like to focus on a little bit is the colposcopy that I had. So the colposcopy is a special camera that looks more closely at the cervix. And the reason I raise this is because it was during the colposcopy that the consultant gynae-oncologist stated that he could see a visible mass and that he did biopsies and that I needed further investigations. Now, I was a bit mean and a bit unfair, and I did put him on the spot and ask him outright if he thought that this was cancer. And because of his amazing interpersonal skills, his communication skills, he dealt with being put on the spot very, very well, and was honest with me and told me that the chances were very, very high that this was a malignancy, but that actually we needed to get the biopsies back and that I needed further investigations, including MRI, CT, PET scan, etc. Now, whilst I was waiting for the MRI and CT to be organised, I was actually admitted as an inpatient via ambulance. I had fever of, I think it was 41.5, uncontrolled shivering, so rigors, and most hideous pelvic pain. Even Entonox didn't touch it. It kind of was worse than labour pain. So when I was admitted, I was very, very fortunate that my gynae-oncologist I'd seen for colposcopy had discussed my case with another gynae-oncologist who was actually at the hospital and who came to see me. And again, what I remember more than anything, although it was scary being in hospital and being poorly, was how good she was at communicating and listening. She listened to the fact that recently my husband and myself had a dear friend that had died from breast cancer, so that was adding to the anxiety and the fears. And she took that on board, and she made sure that I got my MRI and CT scan organised very, very quickly, and that she booked me in to be seen in the clinic very, very quickly after MDT. In fact, I think it was the same afternoon. And it was nice having that kind of that rapport being built and knowing it was her that was going to be giving me my diagnosis. Next slide, please. So when I went to see the oncologist and she was there with a clinical nurse specialist to deliver the diagnosis. So the diagnosis I was delivered was that I was stage 2B. So, you know, not very early stage that could be treated with surgery, but not, you know, very advanced stage either. So it was kind of a, I think what I called a mediocre tumor. They also said that it was a grade 2. So again, not very aggressive, but not kind of mild either. And the reason that I'm raising this is that there have been some changes to the staging for cervical for gynae cancers. So FIGO, who do the staging system, when I was diagnosed, the fact that I had lymph nodes involved in locally in the pelvis didn't actually change my staging. They knew it changes prognosis and it reduces your prognosis with lymph node involvement. However, it wasn't shown in the staging. So I was staged as 2B. Now, the reason I've put at the bottom here is that since FIGO have done their changes, now if I was being diagnosed, I'd actually be being diagnosed as 3C1. Now that's because they've finally taken into account that actually you need to take into account those lymph node involvement. And although it doesn't change treatment, it does kind of change the severity with which you kind of look at it and the realization that actually, you know, it was quite serious. Next stage, please. Next slide, please. So during my diagnosis, they gave me a treatment plan. So they told me very briefly that I'd have external radiotherapy, chemotherapy alongside it, and then brachytherapy at the end. So again, I'm not going to go into great detail. The external beam radiotherapy for me was done Monday to Friday with chemotherapy on one of the days alongside it. And then at the end of that was the brachytherapy. Now, due to the acute side effects, which I'll talk about in a second from the chemotherapy, I only had 3 out of my 5 cycles. And so I had a few extra external beam radiotherapies added on. Now, the image that you can see there isn't a stock image. That is actually my CT image. So you now know me very much inside and out. And it's just to show you the kind of area with which they cover when they're doing the planning for the radiotherapy. I just found it fascinating. I assumed that when they treat it, they just literally treat your cervix, that it's a very small area. But actually, as Lisa showed in her slides as well, they cover quite a much wider area. And I'll talk about the relevance of that scan image later on one of my other slides. Now, what I'd really like to focus on to do with the treatment is the brachytherapy. Now, I know in a few of the forums that I attend that brachytherapy is something that always comes up as a bit of a fear for patients, and it did seem quite scary when I Googled it and looked up what it was and what it looked like. It did look like something out of a bit of a Victorian horror chamber. But actually my experience of brachytherapy was nowhere near that kind of image that I had, that it would be scary and painful and traumatic. So what made the difference for me was the amazing communication skills of my team that I had. I had the most amazing clinical oncologist who listened and took into account everything that I kind of fed back to her. I had a brilliant anaesthetist who gave me excellent sedation and a brilliant spinal, so I felt absolutely nothing. I was blissfully unaware. And the actual team around me who supported me whilst I was lying there for hours waiting to have the treatment done, and during having the implements put in and taken out, were brilliant. In fact, I remember one of them more than I remember anything else about the treatment is that I remember there was one brachytherapy, one of the brachytherapy team who was amazing. I remember she had the most fantastic glasses and she was so funny. I remember being really worried that I was going to dislodge something that they'd spent so much time putting in place, because she just kept making me giggle so much. So, and yes, you know, it was painful and I needed pain medications and it was long and it was stressful. But actually looking back now, what I remember aren't those negative bits, was the people who supported me through it. And I really wanted to emphasize, you know, that if you've got that really supportive team around you, it can make such a massive difference for the patient. Next slide, please. So I mentioned my side effects. So again, I won't go through all of them, but the ones that I really wanted to focus on was the fatigue. So the fatigue was one of the things that I probably didn't expect as much. I was aware of the nausea and the vomiting, and that was horrendous. I have to say, I lost a lot of weight very quickly. Probably looked my best, but I had a lot of baby weight. But the fatigue side of things, I wasn't really prepared for. And the fatigue was very overwhelming. I remember sitting on the bottom of my shower floor, just letting the water wash over for about 10, 15 minutes, and then going back to bed for about 4 hours afterwards, absolutely just physically exhausted. You know, just trying to stand to say goodnight to my daughter was just overwhelmingly tiring. And that was made worse by having the radiotherapy alongside it. Radiotherapy can cause fatigue as well as the chemotherapy, which again, I didn't really kind of expect. And having them together just kind of made each other worse. Adding into that, the bladder symptoms and the diarrhea and the frequency and urgency, and then the peripheral neuropathy from the chemotherapy. So I had cisplatin, and I think I was higher risk. I'd had peripheral neuropathy problems after I'd had my daughter. And because I already had a pain condition, I think I was kind of predisposed to experiencing more pain issues with that. But the pain from that, so my feet felt like raw flesh, like when you've burst a blister and you've got that new layer of flesh there. I remember living in flip-flops a lot, and it was January, February in Kent, so not warm. But actually that peripheral neuropathy added into the fatigue. It's exhausting kind of trying to manage that pain as well. Now, the reason I mentioned the peripheral neuropathy, next slide, please, is because actually, I think the neuropathy and the chemotherapy that I had not only impacted the acute side effects, but from looking into the research, it actually increases your risks of the long-term and late effects as well. So for me, you know, my long-term effects that Lisa was talking about earlier, things like the chronic bowel issues and the bladder issues, which started during treatment, but then although they changed and they did become easier, they've never gone away. And I've learned how to manage that. They were very much those long-term effects. Same with the peripheral neuropathy. But the late effects that I experienced, so the problems from menopause with the sexual dysfunction and the musculoskeletal issues, the peripheral neuropathy is very much related to the musculoskeletal issues. So having chemotherapy, especially platinum chemotherapy, alongside radiotherapy to the spinal area increases your risks of having those kind of spinal changes. And yes, I've mentioned on there my rubbish tattoos. On the previous slide, there was a little image of my tattoos, which they use for radiotherapy marking. And I kind of wish that in the future they would train up people to do butterflies, skulls, something different to just weird kind of prism dots, which aren't very flattering. Sorry, next slide. And next slide. So the spinal issues that I was talking about relates to what Lisa was mentioning in her talk about the neuropathies that can happen. So radiation-induced lumbar plexopathy is something that isn't very much studied. There's not huge amounts of literature out there. I think recently doing a literature search, I found about 40 articles, not all of them particularly relevant, and none of them covered the experience for the patient, very much as Helen found with the GI effects when she was doing her studies. And the reason I wanted to talk about this here, apart from the fact that I've experienced this myself, is that I wasn't aware of it at all. In fact, the first time I'd ever heard about it was when I went to see Lisa in her late effects clinic, and she showed me the scanning, and she talked about the MRI scan, and actually just below where that orange line is, you can see a very, very kind of, the grey area is slightly darker at the very top of the L4 vertebrae, and the orange line kind of maybe should be a bit lower, but that kind of shows you where the radiotherapy affected the bone marrow. So the lighter areas below the orange line are where the bone marrow has changed and kind of converted back to how it is when we're younger. I just found it really fascinating and a bit geeky, so I thought I'd include it as well. But the radiation-induced lumbar plexopathy, as Lisa said, you know, for me, it came on a couple of years after I finished treatment. I suddenly realised that I wasn't able to stand up off the floor without pushing down on something, doing inclines, so going upstairs or going up hills. I found my legs felt very, very weak. I started developing fasciculation, so little tremors in the muscles. My kids had loads of fun poking them, trying to get them to stop. And it was quite worrying, and it was, you know, brought up a lot of anxieties about what could it be. You know, your automatic reaction is to go to that fear of recurrence. You know, is this a tumor that's causing it? But actually having the scans and having that reassurance when I went to see Lisa that, you know, these are explained and they're to be expected for some people, especially with my history, then it just validated that experience, and it made me realize that I wasn't crazy, that this can happen, and that it is quite a genuine thing to experience that needs far more research into to see what should be done. As Lisa said, luckily now they are taking into account and looking at it as a protected organ. So hopefully in the future, the risks of this will be far, far less. But in the meantime, we still need to find more ways to make sure that people are supported in the right treatment. One of the other things that I want to mention related to the fear side of things is obviously this fear of the late effects, fear of recurrence. But two of the things that I think aren't really mentioned and aren't really looked at very much is the guilt and the grief that people can experience. So I know I've experienced myself. So that guilt around what I couldn't do during treatment, not being able to play with my kids. I had so my little boy was 16 weeks, I think, when I started treatment, and not being able to do things with him, having to stop breastfeeding. That was obviously, I felt very, very guilty about that. Having to rely on friends and family to take over some of the burden that I as a mum should have been doing. But then there was also the guilt about, you know, the survivor's guilt that I've had more recently, so more of a later effect. And so there was people that I met who went through treatment at very similar times of me who haven't survived and have died because of cervical cancer. And there's always that kind of thing of why them, why me kind of thing. And it's something that isn't really discussed as much. And I just wanted to really raise that that's quite normal to feel that way, and that there is support out there. The other part that attaches to that is the grief. So, you know, the losses that you experience when you go through treatment, the things that you miss out on, and also the things that maybe you had to give up because you were going through treatment or because of the consequences of treatment. And again, it's not really very widely talked about, but it's something that has a massive impact at the time and later on as well. Now, for me, I was offered counselling when I went through treatment, but I didn't really feel it was the right time. When I was going through treatment, I was very much in the mind that my full-time job was to have treatment. It was to, you know, go to my treatment, have my radiotherapy, have my chemotherapy, and to get better. But it was a few years later that I realised that actually, having time had passed, I needed to reflect on what I'd been through and how that had affected me to be able to kind of process it a little bit more. Next slide, please. And the brilliant thing that the Macmillan counselling service that's available was absolutely phenomenal. I accessed it locally to where I am now, and they were absolutely brilliant. But it was lovely to know that no matter what part of my journey that I was on, that actually they were there and available. So it's having that knowledge that these services are available. The other thing, as mentioned, obviously, is seeing Lisa. So finding the Late Effects Clinic at Taunton. which for me I found through social media. So I am forever indebted to the wonderful Leslie from PRDA, who actually told me about the Late Effects Clinic. I think because there aren't many late effects clinics around the country, although they are growing, thank goodness, people aren't always aware of them. And actually even my oncology team weren't aware that the late effects clinic existed. And so, you know, it was very, very fortuitous that I managed to find her. And the experience of going to the late effects clinic and meeting Lisa was phenomenal. To have a truly kind of person-centered care. Literally, I think I was there 2.5 hours, bless her. She must have been exhausted. And to go through your symptoms, to go through, you know, what symptoms you have, why you experience them, what you can do about managing them, what services or what options are available if, as she said, about the conservative approaches don't work, what else can be done. It kind of gives you a bit more hope that you can get back to some normality, or at least learn to live alongside them. So that was really important. And obviously, you know, apart from finding Lisa on social media, it's brought me to the wonderful charities that have allowed me to do this today. And for me, raising awareness and being an advocate for other patients going through treatments and trying to improve the support that's available, or at least the awareness of these possible effects, is really, really important, and a really positive distraction for me to channel what I've been through and my experience into something slightly more positive. But don't get me wrong, it hasn't all been positive. It has sucked quite a lot at times and continues to do so, but actually it's nice to feel that I can do something positive, what could just be really awful and traumatic. And it was because of the support that I had from all of the different teams that enabled me to get to this point where I could. So a big thank you to everyone that supported me through diagnosis, treatment, and is continuing to support me now, including the amazing Kim and Sam and Action Radiotherapy and everyone else who's allowed me to do this today. So next slide. So that's me. Thank you very much for listening and for attending and allowing me to do this as well.
Rhea, thank you so much. I think we all agree we can learn so much listening to patient stories, and just thanks for your willingness to share and your honesty. I know you tell me that you don't mind going over this stuff to help raise awareness, but I know it can't have been easy. So from everybody, I just want to say thank you very much for that. I think we've got some time for questions, which is fantastic. And I'm just going to stop sharing so we can look at the questions we've got. Okay, so I have one that I want to ask to Lisa, if that's okay. And this is, do you think that new techniques, IMRT and VMAT, have minimized side effects in recent years? And should adaptive planning be routine?
I hope you can hear me. I think, so for people that don't work in radiotherapy, it's a way of delivering radiotherapy quite accurately and quite conformably to the bit you want to treat. With IMRT and VMAT solutions, though, we end up treating a lot of the patient. And realistically, in the long term, we don't really understand what even low doses are going to do over a very long period of time. I know with some of the endometrial cancer cases, it's still not fully decided as to whether IMRT and VMAT solutions decrease the late side effect burden. In terms of adaptive planning, so that's coming up with a plan that fits that patient's anatomy perfectly every day. Yes, we should be moving towards that, because as I said, the only way to not develop late effects is to not deliver radiation. So if we can minimize the doses as much as possible to normal tissues, then in the long run, it's got to be a good thing. I hope that answers that.
That's brilliant. I'm just looking for a question that we had in about enemas, and I can't find it in the Q&A. So I'm going to hand over to Helen, if that's all right, who can find the question.
I saw that question about the enemas. Yeah. So question is about the steroid and sucralfate enemas. So it's interesting. You're right that some people do treat with steroid enemas, but what are they treating? So steroids treat inflammation, and as I was saying, certainly from 3 months afterwards, this is not inflammation that you're treating. So really, there is no reason why a steroid enema would work. Sucralfate, the enema that works it acts as a temporary barrier on the bowel. So it's a bit of a tricky preparation to make up. Some pharmacies will make it up for the patients into a 50ml syringe. Otherwise, sometimes people have to like mix it up themselves, like doing a bit of cooking. And then it's applying this medicated enema via the syringe inside the bowel and sort of roll around on the bed twice a day. And it just puts a temporary cover on it. So for some people, it's great. For some people, it's not worth it. It just provides a temporary cover. But often, if the bleeding is not too bad, once the patient is aware of where the bleeding is coming from, and actually you can only do that if you physically look inside with a flexible sigmoidoscopy or a colonoscopy, then once they're aware that this isn't a new cancer, that actually most people cope very well with mild bleeding as long as they're not becoming anemic, which is actually quite a common problem.
Thank you very much, Helen, for answering that. I just spotted another question that would be great to ask Rhea, if that's okay, from Fern, who just wondered if you wish the late effects of treatment had been discussed with you more in detail prior to or during treatment. Do you think it should be emphasised more?
Yeah, so I think definitely they should be part of the consent process. So you need to have informed consent. I think my team were great and they did inform me about many of the acute effects and some of the maybe more long-term effects. But I don't think, certainly not things like radiation-induced lumbar plexopathy. And I know it's rare, so they're not necessarily going to raise it. But I think there should be more awareness. And I know I was given a booklet from Macmillan about late effects, but again, things like radiation-induced lumbar plexopathy weren't really included in great detail or very much at all. And that's something that I think is being worked on at the moment. There's quite a bit of work going into updating these things as well as more information comes out. So I'm hoping that having a bit more of a full booklet that includes all the possibilities. I think it's difficult, isn't it? It's a fine line between scaring people off and people thinking, oh my goodness, I don't want to have treatment, because they are still quite rare for many, many people. But I think especially if you are, like myself, probably a bit more high risk of developing them, then it should probably be discussed a bit more, at least discussed that you have a risk of it, definitely.
Thank you, Rhea. That's super interesting. We've got another question for Lisa, if you can answer on this, about raising awareness with GPs in primary care. So they don't always have the information necessarily to help diagnose late effects or refer on. So can you speak on that and what might help?
I think one thing that's really going to help is radiotherapy centres producing really good treatment summaries that go to the patient and to the GP when they leave. So this has been rolled out so far for prostate, breast and colorectal cancers. And it documents in there potentially what people can expect to happen in the future. And if it does, who they can get in touch with. So again, it's not just for the patient, although the patient can then alert their GP, actually, I think I've got this, can you contact this number? But for the GP as well. I think as radiographers, part of our role should be also engaging with the wider healthcare scene. So perhaps talking at GP conferences, which we try and do, or producing resources for GPs. And Macmillan do actually have some resources for late effects for GPs, so like a toolkit, so they can tap into that and have a look. I think, again, it's just this thing about raising awareness, isn't it? But actually making sure that the patient has the information so they can then take that to their GP as well.
Thanks, Lisa. We just want to ask Rhea a question here that's coming from Gillian. Did you find any of the treatments more difficult to deal with than others? The chemotherapy over the radiotherapy and the brachytherapy?
So acutely, 100% the chemotherapy. 100%. I remember saying to my clinical oncologist when she visited me in one of my hospital admissions with nausea and vomiting, that I just wanted them to stop the chemo. I didn't want any more. They could give me all the radiotherapy in the world, but no more chemo. And they did listen and they took that on board and they stopped the chemo at that point, which is why I only had 3 out of 5. And they added some more radiotherapy on at the end. I think acutely, the radiotherapy was really quite easy to manage initially because you don't really feel anything to start with. It's just like going for an X-ray. You can't tell anything's happening. It's only a few weeks later that you start to realize that something was happening. The brachytherapy was quite, the symptoms were quite distressing with the cystitis and bleeding and things like that. But actually that all settled very, very quickly. And the brachy was the one I was scared most about, but actually was probably the easiest. Long term, definitely the radiotherapy has had more of the complications for me than the chemotherapy. I still have some tinnitus from the chemotherapy and the peripheral neuropathy, but they're quite easy to manage compared to the bowel issues, the bladder issues, the leg pain, the weakness and everything. So yeah, I think it was quite interesting. Acutely, the chemo was worse, but radiotherapy long term has definitely been harder to get my head around and learn to manage.
Just before we finish off, Rhea, can I just ask you, knowing what you know now and about late effects and how it affects your life day to day, would you still make the same decision to go ahead with the treatment that you had those 4 years ago? 100%
yes, definitely. I'm still here now, and the treatment did its job, and I get to meet amazing people like you. Don't get me wrong, I'm not saying that there aren't moments where I have my own pity parties and things suck and you kind of think, oh God, but actually in the whole, it's manageable when you've got a really supportive team. And I think that's the most important thing. I think if I didn't have that support around me, I didn't have, access to Lisa and supportive friends and family and things, that might be a slightly different answer. But yeah, no, definitely with the right support, 100%.
Oh, that's amazing. I think we are going to wrap up now, and I'm just going to go back to a thank you slide and thank all of our speakers and our webinar team. We can carry this conversation on Twitter. We've got our hashtag RTLateEffects. We'll try and go through some of these questions and make sure that we can answer them for you. So yeah, huge thanks to the speakers and the moderators. Huge thanks to you, the audience, who've tuned in to learn a bit more about this late effects topic. If you liked it, if you thought it was engaging, informative, you learned something, then we would invite you to make a donation to one of our organising or supporting charities. Any amount you can give will make a difference to the work that we can do. So information about donations will be coming to your inbox together with a very short feedback form to help us gauge, evaluate this event and potentially plan for something new. So thank you everybody for tuning in. And goodbye, good night, have a good rest of the day and be safe. And thank you.